Are we saying maybe this is more of a unicorn than a Hebra, perhaps?
Unicorn, I like that.
Yeah, it's like a disease that doesn't actually exist. I mean, as much as we'd love for unicorns to be real, I'm pretty sure they're not.
Yeah, I think it's really good to have a term for sort of make-believe diagnoses. Yeah, unicorn is great. Hey, Cyrus, do you hear something?
Yeah, what is that? Nick, that sounds like a stampede.
You were supposed to say hoofbeats.
Of course. As in when you hear hoofbeats, think horses, not zebras, right?
That's right. Or is it? So on today's show, we're going to talk about that old adage and see if it's really true in the modern ICU.
On that note, welcome to Critical Care Time, the podcast for everyone who takes care of the critically ill. I'm your host, Cyrus Askin.
And I'm Nick Mark. On this week's episode, we're going to revisit that the old horses and zebras and reinvent it a little bit with something we're calling Zorses and Hebras, a new take on the old adage.
Yeehaw! Giddy up! I think we should start by reminding our listeners about the traditional paradigm of horses and zebras in medicine. So I guess we could talk about who coined the term?
Yeah, sure. Who do you think it was?
I mean, it had to have been Osler, right?
Osler is never a bad guess. Like, if it's anything clinical, guess Osler. If it's anything pathological, guess Virchow, and you're probably right. In this case, no, though. It was a different physician in Baltimore, someone named Theodore Woodward. He wrote, quote, "When you hear hoofbeats behind you, don't expect to see a zebra." He was also frequently known to say, "Don't look for zebras on Green Street," which is apparently the big street outside the University of Maryland Hospital.
Interesting. So essentially, he's saying that all things being equal, a more common disease is a better explanation for whatever's going on than a rarer one.
Exactly. Just like an Occam's razor for medical diagnosis.
Exactly. And, I also really like this definition from season 1 of Scrubs.
So, judging from the ataxia dysarthria and the mental status change, I've concluded that Mr. Yeager is suffering from Kuru. Kuru. Yes, Kuru.
Wow, I'd actually never thought of that.
Hell yeah.
Were you aware that the only documented cases of Kuru were members of a cannibalistic tribe in eastern Papua New Guinea?
I was not.
Actually, Doc, I was in New Guinea just last week.
Really?
No.
Newbie, do you happen to know what a zebra is?
That patient just mocked me.
It's a diagnosis of a ridiculously obscure disease when it's much more likely that the patient has a common illness presenting with uncommon symptoms. In other words, if you hear hoofbeats, you just go ahead and think horsies, not zebras. Okay, Mr. Silly Bear?
I love that. I love that clip. That show is great. And that is the absolutely perfect definition. So no offense to the esteemed Doctors Woodward and Cox, but I think there are two problems with that traditional horses and zebras model that we want to talk about. Number one, it implies that diseases are either common or rare. And there's actually a lot in between those two. There's a lot of space in between there. And it also implies that we know which are which. And I think that's actually one of the big problems that we need to talk about today.
Whoa. Okay, so you're saying that there's a model where common diseases are horses and rare diseases are zebras, and that's too simplistic?
Yeah, too simplistic. We need to add some more categories. Fortunately, nature has come through for us here, and we've got some great names for them. So there are conditions that we think of as rare, but they're actually surprisingly common. We're going to call those Zorses. And then there are conditions that we think of as being common, but in reality, they're actually pretty rare. And we'll call those Hebras.
Okay, so to summarize, we just need two more categories beyond horses and zebras. Horses being common diseases, things like asthma, COPD. Zebras are rare diseases like Mediterranean's disease or, I don't know, Kuru, to use an example from Scrubs.
Kuru is definitely a zebra.
Yeah. And so then I guess a Zorse is a disease that seems rare, but it's actually quite common. And a Hebra seems common, but it's actually rare.
Exactly. And for those who are wondering where I got those names from, in nature, there are these animals called zebroids, which are a cross between a zebra and another horse species. So, for example, a Zorse is a zebra stallion and a horse mare, and a Hebra is the opposite. But in case you're wondering, zebras can also mate with other species of horses, and they can produce offspring with some awesome names.
Man, Nick, you really gone off the deep end here, brother. This is truly fascinating. So come on, what are the examples? Give it to me.
You'll bite. Okay. So a cross between a zebra donkey is called a.
We'll go with zonkey.
Nailed it. How about a zebra
Nice.
and a pony?
That's got to be a zony.
Got it again. All right. What about a zebra and a mule?
A zebra and a mule. Let's see. Let's go with Zool.
Yeah, that's the villain in Ghostbusters. We should
dang
probably bring
it.
this back to critical care before our audience thinks we're just a couple of zasses.
Yeah, I don't think we want to be known as the zassholes on social media. So to summarize, okay, so we've got our horses; those are our common diseases. Our zebras; those are our rare diseases. And then we've got these Hebras; their diseases perceived to be common but actually rare. And our Zorses, which are diseases that are perceived to be rare but actually common.
Yes, exactly. Great summary. And I think this will make a lot more sense when we talk about some examples. So we've collected a couple, and let's discuss those kind of one by one.
Okay. So one that I can't say, can't really say enough about, having taken the critical care boards not too long ago, is Cefepime-induced encephalopathy, which I'd say is a definite Zorse.
Definite Zorse.
Yeah. So, so Cefepime-induced neurotoxicity, it's a good thing to know about, especially since we use a decent amount of Cefepime in the ICU. And it's typically manifests as impaired consciousness, myoclonus, disorientation, and sometimes you can even see non-convulsive status epilepticus, which of course begets a whole host of problems that we'll no doubt talk about in another episode.
That's exactly right. And I think, we've been using more and more Cefepime recently. I think both because of resistant organisms, we're tending to use a fourth generation more, but also there have been shortages of piperacillin tazobactam. So a lot of hospitals have switched their default from one to the other. And then there's also concerns about Zosyn and vancomycin together causing nephrotoxicity. So a lot of places are using more Cefepime, and I think they probably don't realize that they're exposing a lot of patients to harm by doing so.
Yeah, and I think, to be a bit more granular, so, Nick, I think up to 15% of ICU patients can develop encephalitis secondary to the use of Cefepime. And as we sort of alluded to, you can see seizures in these folks, and that may include non-convulsive status, which is rare, but of course still should be noted. And I guess, Nick, so remind me, how is Cefepime cleared?
It is renally cleared, and so that is a big problem because patients in the ICU who either have CKD or AKI, we often overdose them on Cefepime, which probably contributes to this. I mean, one other way to think about that: 15% is just a massive number for a drug side effect like this. 1 in 6 number needed to harm. Like, this is definitely a drug that we need to be very cautious about, and a drug that we need to, point our finger at more often and sooner, I think, especially when somebody is like slow to wake up, slow to wean from mechanical ventilation. Like, get the Cefepime out of there and see if they wake up. And I'm constantly amazed how often Cefepime is the culprit.
I think that's a really great point for our audience, and something that I don't immediately always think of, especially, I don't know, Nick, about you, but where I practice, there's pretty good number of times when we're using Cefepime instead of piperacillin tazobactam, and I mean, it's almost like it's a super common drug, and this is a pretty common side effect.
Super common where I work too, and I think this is a reminder that it's probably broader than you need, and stopping the broad coverage sooner is beneficial. And when you have a drug that can make as many as 15% of ICU patients have neurological symptoms, that's a drug you want to get out of there if you're concerned that somebody is slow to wake up, for example. So this is a definite Zorse, a condition that we don't think about enough and is actually probably quite common.
I think it's great that we hammered that home. It'll be great for my practice as a reminder. And really, I think for me, the real key point is, if ever there was a horse in the ICU, that would be AKI. And, to know that there's that relationship between AKI. Oftentimes we see AKI in our septic patients. They're often empirically started on Cefepime. So probably should be really on the forefront of everyone's mind if you're working in an ICU setting.
Absolutely. All right, I've got another Zorse, and it pains me a little bit to say this one, but dexmedetomidine-induced fevers.
No, not Precedex.
I know it's a great way to avoid worse drugs like benzodiazepines. Some people, like absolutely love this, using Precedex in the ICU, and I'm one of them. But it does have a price. It's in about 3 to 10% of people who are on a dexmedetomidine infusion, they will develop fevers, usually about 48 hours after starting the infusion. Sometimes it's sort of just a steady increase in temperature. In some people, it can be low grade, but in a subset, maybe about 3 to 4%, they can have temperatures over 39.5 or even above 40. So quite hot.
Geez, yeah, that's no joke.
It's also kind of worth noting that the incidence of this is higher in people with obesity and people following open heart surgery. There's a thought that maybe mechanistically what's happening here is that dexmedetomidine is having some effect on adipose tissue and it's causing heat generation. I don't think we really know mechanistically why this happens, but it is clear that if you stop the Precedex, you stop the dexmedetomidine, the fever will go away and rapidly, usually within just a few hours.
Got it. Okay, so it sounds like I don't need to stop using dexmedetomidine. Please don't tell me I need to stop using.
No, you do not need to stop using
Okay.
this. It's a good drug. I think the key thing is that we need to be vigilant for fevers in people who are on dexmedetomidine. Remember that 3 to 10% of our ICU patients on Dex will develop fever. Number needed to harm, pretty low, actually.
Yeah, and that's I think an important point, and it's not. When we were in pre-recording, we were talking about this. It's not so much the fever per se that's going to harm our patients. It's all of the workup that could potentially generate in searching for this hidden source of fever when it's sort of right under our nose. Is that kind of how you look at it?
Exactly. I mean, increasing their oxygen consumption might keep them on the ventilator longer in some cases, but it's also all the other things that we subject them to. And, God forbid we put them on Cefepime and then they develop encephalitis from that. Then one Zorse has led to another Zorse.
Man, that's a great point and a great connection between two Zorses.
Do you want to share another Zorse?
Oh, sure, absolutely. So I guess I was actually pondering what happens when two Zorses mate. What comes from that?
Man, yeah.
And I don't think I have an answer.
Not to ruin anyone's imagination, but apparently all zebroids are sterile. They can't produce crazier named offspring. So
yeah, that's right. We'll just have to leave it to our imagination.
That's right.
But okay, cool. So we've talked about a couple Zorses. How about one more Zorse? I'll go with Wernicke's encephalopathy.
Good one.
Yeah, so definitely a good one to talk about. So we'll often see this in the setting of folks that are coming in with a history of alcohol use, and really what it is essentially is a degenerative brain disorder due to a thiamine deficiency or vitamin B1 deficiency. And that's thought to occur because, of course, thiamine is a necessary cofactor in the citric acid cycle. And so when it's absent in specific brain areas are forced to switch to producing lactic acid, kind of can become problematic. I don't know, Nick, do you want to hammer that home at all anymore? Or
yeah, no, I think it's a surprisingly common deficiency. We'll talk about who gets it in a second. And it can have a couple different manifestations. This is one of those diseases that classically presents with a triad, but often doesn't actually have the full triad. The triad is ophthalmoplegia, which is often either a lateral rectus palsy or lateral nystagmus. Ataxia, which can be everything from imbalance, Romberg, gait disturbance, and then confusion, which is a pretty vague one. Often it's described as confabulation as well, but it can also be a bit vague. But I think it's worth pointing out that many cases, and especially the cases that aren't related to alcohol, seldom have all three parts of the triad. So it's an easy diagnosis to overlook. And, and unless you're really doing a really good cranial nerve exam, the lateral rectus palsy or even the lateral nystagmus may not be obvious unless you go looking for it. So this is a disease, this is a Zorse that you will not recognize unless you go searching for it, I think. Should we talk about who gets Wernicke's?
Yeah, so I think as I sort of alluded to, at least I think of it in patients that are suffering from alcohol use disorder, those coming in with acute alcohol toxicity with perhaps a long history of alcohol use. But then there's also those that are post bariatric surgery, particularly those that have had Roux-en-Y surgeries. I think more so than gastric sleeves and some of the other less invasive bariatric surgery options that are out there. And then it's also something that I think we can see in the general population, particularly those that are chronically undernourished. Perhaps, there's unfortunately a growing population of undomiciled individuals in America and across the world. And so those folks who are unfortunately not able to have more robust or nutritious diets are certainly at risk for this. So,
right. And so just to hammer home those points about incidence, so 12% among people who chronically abuse alcohol, maybe as much as 5% among people post-bariatric surgery, and unknown among people who are chronically undernourished. And I think that last population is a population where it's really easy to overlook if you don't think about it.
And so what do we do for it?
Well, this is one that it's not a stop the med, but it's a straightforward treatment, a high dose thiamine replacement. 500 milligrams 3 times a day. And usually within several days, you can see improvement on this. I think it's also important to remember, though, that people, especially people who have problems with malabsorption or have a chronic undernourished state, are often deficient in other vitamins too. So it's probably appropriate to think about all of the other vitamins and make sure you're replacing those as well. Even if thiamine is the culprit for Wernicke's, they may also have deficiencies of folate, B12, and many others.
That's awesome, Nick. I think it's good to know. It's of course a pretty easy treatment, but then also considering that birds of a feather flock together, and so if they have one deficiency, they might have several other deficiencies, and it's always good to be vigilant for that sort of thing.
Zorses keep company with Zorses, as we've learned.
Yeah, exactly. Yeah, for sure. So maybe that's a good opportunity for us to pivot to some of these Hebras that we were talking about earlier. So, yeah. Nick, do you happen to have a Hebra for us?
Yeah, I've got a good Hebra. Contrast-induced acute kidney injury.
Oh, so tell me more.
We're jumping into a little bit of controversy here, but I think, this is an interesting example of things that existed 50 years ago might have been a horse, but now they're a Hebra. And just to give some details. So contrast-induced AKI is defined as a rise in creatinine of 0.5 or a 25% increase from baseline within 48 hours of getting contrast. And this probably used to really be a thing. Back in the 50s and 60s, when they gave you contrast, it was really high osmolality, and it probably caused quite a bit of kidney injury because of that osmolality. Modern contrast is not high osmolality, though. Modern contrast formulations probably do not cause AKI. And we know this because there have been actually quite a few really good studies. There are at least 8 large observational studies that have failed to find robust evidence of AKI after contrast exposure using modern contrast. And there was one other study recently that we could nerd out for a bit, or we could sort of skim over. But basically a study that looked at people who got contrast or didn't based on small differences in their D-dimer, people who were just above the threshold or just below. And they found that the patients who had a slightly higher D-dimer and got contrast actually had identical outcomes to people with a slightly lower D-dimer who didn't get contrast. This technique, it's called regression discontinuity, is a really robust way of testing observational data. And it also suggests that probably in the modern era, contrast-induced AKI is, at the very least, quite rare.
Right. Yeah, and that's kind of how I've viewed it as well. Typically, where this often comes up is when we're talking about pulmonary embolism and trying to rule in or rule out PE. And, I think, I think I recall having a discussion with the Kitty Boy with Dr. Joel Toff about this on air at some point. And basically, if you're worried about PE, if you're worried about a life-threatening diagnosis, just get the dang study. And there's not any reason to sort of like hem and haw over what, as you sort of outlined for us, is a pretty rare entity, if even an entity at all, given the advancements in contrast.
Yeah, and actually one other thing that I should add to that is that, so we defined contrast-induced AKI as a rise in your creatinine, but that's not really a very patient-centered endpoint, right? Patients don't care if a number goes up on their labs. They care about what is their long-term renal function and will they need interventions like dialysis. And like I said, there are now many large observational studies that show that patients who are patients that are exposed to contrast are unlikely to develop need for renal replacement therapies or to have a long-term hit in their kidney function. So from a patient perspective, even if their creatinine goes up, they don't tend to have those other complications. And so I really think that this is maybe not an entity that doesn't exist, but an entity that is far rarer than it once was.
Right. And I think that's an important point. Now, Nick, I know that here we're talking about venous contrast, of course, and we do. I don't want to get too far off into the weeds, but I think it's important to delineate. We're talking about venous contrast as opposed to arterial contrast that may be given like in an LV gram as part of a LV assessment during a cath. Do you? For our audience out there, can you maybe touch on why we care more about arterial contrast than venous contrast when it comes to sort of the potential for kidney injury?
I actually don't know what is the reason for that? Is it that it's directly exposing the kidney as opposed to first pass through the lungs, or what?
So that's what I have come to understand. I think that it's usually it has to do with sort of the amount that's given. I think you do give quite a bit for like an LV.
They give a lot more in the cath lab than you typically would in a CT scan. That's definitely true. So the dose makes the poison.
And then there isn't really any opportunity for metabolism. It kind of goes straight to the renal arteries, and then you're sort of directly exposing the kidneys. It's something I definitely want to explore a little bit more, but at least that's the explanation I've always kind of been given. Versus like venous contrast.
The original case reports of it were in patients who were getting contrast to look at their renal arteries. So they were getting high osmolar, intra-arterial renal contrast. And that's where this entity was described back in the 50s and 60s. And so we've come a long way from that. And you got to be careful about extrapolating old evidence to the present where it may not apply anymore.
So I guess all of that being said, are we saying that, this really doesn't exist? Are we saying maybe this is more of a unicorn than a Hebra, perhaps?
Unicorn. I like that.
Yeah. It's like a disease that doesn't actually exist. Like, as much as we'd love for unicorns to be real, I'm pretty sure they're not.
Yeah, I think it's really good to have a term for sort of make-believe diagnoses. Unicorn is great. And I love that you're injecting a little bit of whimsy into the ICU too.
Absolutely.
Definitely need to use the category of unicorns more in the future. To answer your question though, I would be hesitant to call contrast-induced AKI a unicorn. I do think it's a Hebra, and I think there's a couple of reasons for that. One, there probably are people who are at higher risk of contrast-induced nephropathy, people who have bad CKD at baseline. There's some of these studies that suggest that people with diabetes may be at increased risk. So I wouldn't be totally blasé about giving contrast to people with a high creatinine at baseline. I think we should always decide, is this worth it or not? But I think the idea that this is something that happens frequently, I think we can probably dispense with and say this is probably something that happens much more rarely in higher risk patients.
Got it. So bottom line is going to be contrast-induced nephropathy, or CIAKI, as you might abbreviate it, is a Hebra. Much rarer than we think, but it probably does exist in certain populations.
Perfect. I think that's a great summary. Should we do one more?
Yeah, let's do one more, Nick. I know one of your favorites to talk about. We've talked about this a little bit. Is a zebra. Fentanyl wooden chest syndrome. Nick, can you tell me a little bit about this? Because this one I think this is one of your little pets.
This is a totally pet zebra of mine. So this was first described way back in the 1950s. What they saw was that when people were given high doses of intravenous fentanyl, they sometimes developed this really intense chest wall contraction. Chest wall muscle rigidity, which led to poor compliance of the respiratory system. And in many cases, it was really hard to ventilate. In some cases, it's also been described as involving other muscles. So they might even have trismus of the jaw, myoclonus in extremities, like basically very, very intense muscle contraction. And by the way, this is thought to be related to kind of off-target effects, that it's actually through noradrenergic signaling, not opioid signaling.
I would not have guessed that.
So the person's respiratory drive could actually be intact, but their muscles are tensed and they can't breathe, which has got to be a really terrible situation. I think in terms of how common is this, I think the best answer is we don't know. So since it was described in 1952, there have been like a couple dozen case reports of it. But there's a couple of things that make me wonder if this is actually more common than we think. So back in the 90s, they did this absolutely bonkers study that I do not know how they got past IRB. Basically, they took a dozen healthy volunteers and they gave them a very high dose intravenous fentanyl infusion, 150 mics per minute.
No, they didn't.
Yeah, crazy dose. Until they reached a total dose of 15 mics per kilo. And at that dose, which like for me would be like, 1,500 micrograms, like an insane dose, right? But at that dose, 6 of the 12 subjects developed chest wall rigidity. I should note that in this study, they used BiPAP to ventilate them, and they were able to ventilate them, and all 12 of the healthy subjects survived and did fine.
I have so many questions. A first question that comes to mind is, did these patients ever have a bowel movement ever again?
Right. Yeah, exactly. I cannot imagine what the conversation with the IRB was. But then again, this was back in 1993. So like maybe things were totally different then.
Maybe, but that's not that. God help me if that's that long ago. Then that makes me really old. Oh gosh, that's just crazy, Nick. I can't believe that happened.
It's funny. I think one of the differences between like lawyers and doctors is, lawyers are like, the founding fathers got all this stuff right 200 years ago. They wrote this document, which is perfect. And in medicine, we're like, people in the 1990s were such dummies. We should throw away everything they ever wrote.
Oh gosh. Well, this one might be. We may not want to follow this study up with another one.
No,
like that.
I would not want to see this study replicated, but I think we can learn a lot from it. So this was obviously a very high dose fentanyl exposure that elicited this side effect in half of the people exposed. But there are other case reports. There are case reports of wooden chest syndrome occurring in people after doses as low as 8 micrograms per kilogram. So half of what that other group was exposed to. There's even one case report of somebody developing wooden chest syndrome after a fentanyl patch was put on them. And so there might be idiosyncratic low dose reactions. I can tell you anecdotally, I have seen this occur before in patients under bronchoscopy who got relatively low doses of like 100 mics of fentanyl or the equivalent dose of sufentanil. So I definitely believe that this is something that occurs and probably occurs more than we necessarily recognize too.
Man, that's really interesting. Like it's crazy that there's such a wide spectrum of dosing that has been implicated in this condition, which I personally have not seen before. That all being said, I would imagine the treatment is you stop fentanyl, maybe give them some naloxone.
Yeah, that's right. So as with all of these drug toxicities, step 1, stop the offending drug. Step 2, reversal. And you kind of have 2 options here. You can either give them naloxone, which does work, or you can give a low dose neuromuscular blocker. So like 20 milligrams of succinylcholine. This is probably the only time that I would ever use succinylcholine, by the way. But the idea here is that you can relax their muscles enough that they will become possible to ventilate again. So for somebody who's on mechanical ventilation, for somebody who's not on mechanical ventilation, naloxone might be a better choice.
Man, that's wild. So I guess in conclusion, we're gonna call fentanyl wooden chest syndrome a zebra. Is that right?
Yes, wooden chest syndrome is a zebra for now.
Why so mysterious?
Well, I have a hunch about this, and my hunch is that we are probably underestimating the true incidence. I think the three places where we probably are underestimating it. One, in the OR. So patients are getting pushes of fentanyl in the OR, but they're also getting neuromuscular blockers. So we wouldn't see it there. We wouldn't recognize it. Or actually, it wouldn't even be present because they wouldn't get muscle rigidity.
They're getting like the toxicity with the antidote.
Exactly. Then we have patients in the ICU, and how often have you seen a patient who suddenly becomes hard to ventilate in the ICU? They're having peak pressure alarms, and our assumption is maybe they're biting the tube, or maybe they have secretions blocking it. So then we suction them, we fiddle around with the ventilator, and then maybe a few minutes later it gets better. I wonder if some of those events are in fact wooden chest syndrome, that we're just not noticing what the cause is.
Right. Interesting. Yeah.
And then lastly, I kind of wonder if some of the crisis in the United States of fatal overdoses of fentanyl may be related to wooden chest syndrome. There are actually a couple case reports in my neck of the woods from down in Oregon of people who overdosed on opioids and had profound chest wall rigidity to the point where they were very hard to ventilate by medics. And so I wonder if this is an underappreciated aspect of people who are overdosing on illicit fentanyl. And this might be contributing to the death toll of it.
Huh. Wow. Yeah. I'm starting to wonder if maybe this is a Zorse, Nick.
Yeah, I think this is a zebra going on Zorse. I think we should probably, if we make this a recurring segment, we should circle back and talk about this zebroid in a couple of years.
I like it.
All right. So to summarize, if you hear hoofbeats, think horses, not zebras, but be sure to watch out for Zorses.
That's right, Nick. I think the point of this episode, and like we said a few times, I think it'll be a fun little recurring segment, is really to highlight diseases and conditions that are more or less common than we think. So today we talked about 3 Zorses. We talked about Cefepime-induced neurotoxicity. We talked about dexmedetomidine-induced fevers, and then Wernicke's encephalopathy, which are really diseases that are probably more common than most of us think. What else did we talk about, Nick?
We talked about 1 Hebra, contrast-induced AKI, which is probably much less common than we think. And then we closed by talking about a zebra that I think may one day be a Zorse, the fentanyl wooden chest syndrome. And so I think Just to sort of bookend this, just like horses and zebras, Zorses and Hebras are a useful framework to help us correct our calibration in making clinical diagnosis. By trying to kind of correct our estimation of how common or rare things are, I think it can make us better at recognizing uncommon conditions and avoiding wrong diagnosis, which hopefully makes us better at caring for the critically ill.
And that's what it's all about for us on Critical Care Time. I mean, I think this is when you kind of pitch this episode idea first, Nick, I thought it was just a brilliant way to approach some of these medical diagnoses in a fun way, in an informative way, and in a way that ultimately I think will equip clinicians and bedside nurses and allied health professionals alike as we take care of some of these critically ill patients.
Well, thank you. Yeah, I think that's what the show is all about. So yeah, hopefully raising awareness about rare conditions and sort of helping people correct their clinical calibration will make them better at caring for the critically ill. On that note, well, we hope you enjoyed this episode. If you have ideas for more Zorses and Hebras
or unicorns,
yeah, absolutely. Be sure to tweet at us at the show at Crit Care Time, or at us individually at Nick M. Mark or at Askins Razor. Clearly, he is a fan of Occam's Razor.
He is indeed.
Don't forget to follow us on Instagram, critical_care_time, and check out our Critical Care Time YouTube channel.
And be sure to subscribe, give us a like, and please consider leaving us a 5-star rating on iTunes or your favorite podcast app.
And before we go, we'd like to thank all the incredible members of our team for making this show possible. I'd like to thank the production folks over at Podpaste. And last but certainly not least, Kurt Belknap for our awesome theme music, which you're about to hear in just a second. We are fortunate that this episode and all episodes in Season 1 are sponsored by C-Star Medical. C-Star Medical is advancing the science of cell-directed extracorporeal therapy to help restore the balance of a dysregulated immune system in acute kidney injury and sepsis. Check out their website, cstarmedical.com, to learn more.
And just a reminder, this podcast and all related media, including but not limited to animations, graphics, and videos, are the property of Critical Care Time. We would love for you to enjoy and share our content near and far, but just ask that you cite your source. The views expressed within this podcast and any associated media do not reflect the views of the employers of any of our staff members, friends, guests, or Critical Care Time. All references to patients or encounters have been modified to be HIPAA compliant, and thus any similarities to real-world cases are purely coincidental. Finally, this podcast is for educational and entertainment purposes only and should not be used in lieu of seeking medical advice. If you want to learn more, you should check out our show notes on the website, www.criticalcare.com. While you're there, you can subscribe to our mailing list or leave a comment. Until next time, I've been Dr. Cyrus Askin, and thank you so much for listening.
And I'm Nick Mark. See you guys soon.